Thank you all for joining us today. It's wonderful to have you. So for those who are new to IMCAS, can you please give us your name and what you specialize in?
Sure. I'm Suzanne Kilmer. I'm based out of Sacramento, California. I trained with Rox Anderson, so I'm pretty much a device and also any kind of cosmetic treatments, injectables as well. And I'm very excited to be here. Thank you.
I'm Dr. Orit Markowitz. I'm a board-certified dermatologist from Manhattan. I have been running clinical trials for 20 plus years, and my area of interest and expertise is in non-invasive imaging around skin cancer, but more recently in the cosmetic space and dermatology.
My name is Andreas Nikolis. I'm a plastic surgeon, board certified, based in Montreal, Quebec, Canada. And I too, like the rest of the panel, am heavily involved in evidence-based medical research. I split my time literally between clinical and research for almost 50% and really involved in the advent of new guidelines, energy devices, new toxins, and fillers.
So jumping into our discussion on GLP-1, what are some of the most common aesthetic concerns that patients present with after significant weight loss, especially due to the use of this new medication?
What we're seeing is just the laxity, so profound laxity. I think just volume loss, which, again, is contributing to that. So fat loss as well as muscle loss. And I think that's one of the things that we're really trying to get into the program earlier. So they need like tissue tightening, replacement of volume, replacement of muscle, and then how to incorporate that. At first, we were seeing it kind of as it was going, and now we're trying to be a little bit more proactive and get patients involved early on so that we're not always chasing our tail.
Yeah, initially, we weren't really prepared that this was going to happen. And when we started to see our patients, we realized that perhaps, back in the day of some of the medications, the antivirals for HIV, with lipoatrophy, but these patients present differently. They seem to be losing some peripheral fat, hence the skin laxity, and also the muscle atrophy is quite different as well. So it's kind of a new presentation, but luckily we have some medications that we were using back then that we can now creatively have help us in terms of stimulation for today.
It's a very interesting topic, and I think the landscape is completely different. We're living a revolution in the evolution of aesthetics. These patients are presenting very differently. There's almost no standardization of how they actually present because they're all losing weight at different speeds. So you have patients in their 30s, 40s, 50s, and 60s. They're losing either 1 to 5 pounds, 5 to 15. Over that, it's incredible what's happening. So there's a huge diverse patient population. That's the first thing. The second thing is that most patients don't know what's going on. So all of a sudden, they're happy to lose the weight, and then they look in the mirror, and then they see the comments you just heard before from the panel, which is that gaunt appearance, the loss of texture in their skin, laxity, and so on and so forth. But they don't know where to go and what to do, and it's up to kind of the experts in aesthetics to help guide them. And the trick here is explaining to them what's going on. And as you heard, there's some insights that the patients are not aware of. And I think education here is probably the most foremost and most important component of managing them.
So how do you approach the management of facial volume loss in patients who have experienced this sort of rapid weight reduction?
Based on the HIV-induced lipoatrophy, I really use a lot of PLLA in these patients just because they need more long-term volume, and I'm trying to get ahead of it a little bit. Because in the beginning, as you were saying, people would present, and you were looking at them and knew something was wrong, but they were a little bit embarrassed to say that they were on the drug and that they were losing that much weight. But then after some point, they're back in, and it's getting more significant. So I do a lot of the PLLA because I feel like that's giving something more long-term, more just volumization, sort of reinflating the balloon, if you will. So for volume loss, there's that, but there's also the fact that the skin is sagging, which makes them look more, hollow. So we tend to start like going right into like tissue tightening devices as well. I don't do fat transfer, and you probably do, so that would be interesting to hear about that, because again, that would be more long-term. I'm a little more cautious about doing like HA fillers. I'm trying to stay ahead of it, but you don't know exactly how it's going to change. And the tissue is going to move and the filler will move with it. So I think that's something we're kind of keeping an eye on and learning about.
I think that was kind of what I was hinting at as well, that, when you're dealing with a significant amount of atrophy, but now differently the muscle as well and the peripheral fat that's impacting the skin, it's nice to have stimulators. And I think we are using them differently. The landscape has changed than when we first started like 20 plus years ago with the PLLAs. And it was interesting because I think for myself, I was doing a clinical trial with PLLA, SCA, and skincare. And we weren't controlling for this medication back in 2023 because it was just starting to kind of explode, especially in certain pockets. And for myself, the Upper East Side of Manhattan is probably one of the bigger pockets. And so with hindsight, looking back, it was nice to see that those patients actually did quite well. So that sort of reaffirmed that stimulation is helpful in this population. And we certainly worry that there could be migration or other things happening when you're dealing with rapid atrophy, and different age groups respond very differently and need different things and stimulate collagen differently as well. So I'm sure you can probably attest to this more than anyone. It's great to have that, collagen stimulation and fresh skin to then induce collagen when you're injecting as well.
Yeah, no, I totally agree. And I think that the devices also then work better. I always like when things help out the devices that we use. So if you have this new collagen going, you have newer, younger collagen, which has a lower melting point, and you get more benefit than out of the devices. So I tend to do them in combination quite a bit. And there's actually a muscle stim device out there for the face. And so now you're able to sort of recreate some muscle volume because, again, with this drug, there's a huge problem with just muscle loss. And we can talk about this a little bit later on, but that you can maybe maintain some of that muscle by doing body muscle stimulation. And there's some data that shows that as well.
So it's interesting. Historically, we had two populations of patients to compare against. We had the HIV lipoatrophy patients who we treated primarily with PLLA, and we got some fairly good results. Then we had the massive weight loss patients who had surgical tightening of their stomachs and so on and so forth, and lost a tremendous amount of weight in a very short period of time. But they behaved very differently. These two populations behave very differently than GLP-1 patients because they're no longer GLP-1, they're GLP-1, 2, or 3s because those medications are expanding like fire. And what's happening is that the physiology of the skin is very different. Firstly, when the HIV lipoatrophy patients, which was interesting, we presented a masterclass on it yesterday. And when I asked the group, how many of you have treated such patients? It was only 1/3 of the audience because you don't see those patients anymore. So bravo to science and what's happening. So that's interesting. The second is that the massive weight loss patients are malnutrition, completely and utterly. So they do not behave the same way. These patients, because of the speed of which they're losing their weight, do not have that severe element of malnutrition. Having said that, their primary changes are in the skin. Their secondary changes are in the fat pockets, superficial and deep. And we do not know the extent of muscle. I believe that there is, as you said, some changes in the muscle. But when they end up measuring the muscle mass on their body, they end up losing probably about 15 to 20% of it. The problem is picking up 15 to 20% muscle loss on the face is very difficult because the muscles are so thin to begin with. So the thinking now has to change drastically. We have to count on all our history of how we treated all these difficult patients, but now we have to think ahead. And one of the things I heard mentioned before is early on. If there's one key to a successful recipe is to try and convince your patients to come onto this treatment strategy while they're losing weight, not when they've lost it. You're behind the 8 ball, you're already struggling to get the skin back up. So the earlier you start, the better it is. And one of the counseling things that we've told people who are trying to treat these patients is start early and develop your own patient portfolios. Show them what you've done to other patients. Show them why starting early is important, even when they haven't lost the weight, which means that the algorithms for placing PLLA are very different than placing it in somebody who's already lost the weight. You're going to place it higher. You're going to try to keep certain areas volumized and stronger before everything drops and you're trying now to lift it all back up. So the strategy of treatment is completely different, a whole new playing field.
And you have to educate the patients because they're used to getting certain things, perhaps like, I usually come in, this is all I need. I feel great. I'm very thin. And you're looking at them, and as a provider and an empath, you certainly don't want to tell them, but you look 10 years older, or your skin is not looking great, or there's some atrophy. And how do you now educate them that they need a completely different profile of medication? And so it's important that the endocrinologist or whoever is placing them on these medications probably be educated so they can give them a heads up as to what's about to happen, and that their care is just going to dramatically be different if they want to sort of achieve the same outcome.
The only problem is that these are very difficult patients to treat because they have one fundamental fear. And we identified this because we're putting out a consensus paper on it. And we did this through international centers all over North America, Asia, Europe, and the Middle East. And this is coming out in the next couple of weeks. The number one fear of these patients is actually not the economic fear of how much will this cost me. It's not time commitment. It's, will you make me look like I gained weight? This is remarkable. This is something unbelievable. And that's why we're having trouble convincing some of our patients to even start PLLA, because they're sitting there going, well, I look gaunt, but I've never looked this thin in my whole life. And you're going to take it away from me. And that's where education and your experience comes in. And you say, no, we're skin tightening. We're lifting. We're not volumizing extensively. That's not the point. And that's why, as you've mentioned, fillers come at a secondary stage, as you mentioned as well. It's not the time. This is not it. You start by tightening the envelope, and then you rebuild the patients once they have your trust and once they know what's happening to them. It's a very slow process. You really need education, as you guys mentioned.
And showing them before and afters and saying, does this patient look like they're heavier? Actually, they even look thinner, because instead of looking like a square, they're starting to look like a heart.
My question for GLP-1 is, could some of the skin sagging really be an indicator of some kind of metabolic dysfunction that may be at play within the patient? Should you be going back to the source, so to speak, and also considering their current nutrition? If they are looking like they're malnourished, how would you combat that?
I'm going to punt to you. I think you have a good answer for that.
So I think this is a great question. Again, these are very different patients. And now we're starting to see that there are skin changes, which we know about, which we see. But what do you think is actually being impacted equally at this point in time? It's the fat. And what we're finding is that the transmission messages, the transmitters or the stimulators of fat are now being impacted. So we have different types of fat within the skin, and we're now finding that these kinds of patients actually are losing certain markers and gaining others. Hence why there could be a secondary benefit with PLLA, because we now have certain studies that are showing stimulation of adipocyte factors. So now we're starting to attack this on different levels. So you're absolutely right. This is no longer just a skin or fat situation. This is a situation where we're only now seeing, even though the medication's been around for almost 20 years, now you're starting to see the real science of what this medication or class of medications can do. So you're going to see a lot of clinical trials looking at factors, how these factors change, and these are ongoing right now, and how these factors are going to change with PLLA. And we even know some of these factors will be changed with HAs, hyaluronic acid fillers, which is quite remarkable.
I agree. I mean, one of the things that we were seeing with imaging and collagen fibers is the fiber patterns are very different at different points in our lives. And it's not just what we're doing like with PLLA, but also some of the skincare and combining. So going from the top down and bottom up, and obviously whether non-ablative, ablative, topicals, and with imaging, seeing the fibers actually starting to reverse and the collagen being stimulated, the fibroblasts and the nuclei are rapidly changing, which also indicates that pattern of stimulation. And that we're sort of replenishing things, not back to its natural form, and perhaps even looking like a lot of the patients once they are undergoing the procedures. And what I even saw within the clinical trial, where I went back retrospectively and looked at the subgroup that happened to be on the medicine, they were looking even more radiant. So I wonder if their body is like asking for that in a way.
Could be. Another thing you said is it's really a multi-layer approach. And today Rox was talking about how for the energy-based devices, If you get the heat into the reticular dermis, you're going to turn on fibroblasts that are way better at producing collagen that has tightening. In the papillary dermis, you're going to get like the smoothing and like the superficial crinkling better. But these guys need everything. They need multi-layer devices. They need tightening. They need stimulation of muscle. Add in the PLLA, which, we have collagen and elastin we've known about. Now we can stimulate fat. Everybody knows as you get older, you lose fat, you lose weight, you lose fat in your face. And they always say it's your face or your body. Although I think you're right for sure that they don't like the idea of looking heavy, the fact that they are looking square and not the heart face is something that they really do, want to address. So we need to put everything into our armamentarium
I
and
agree.
starting early.
And that has to do with whether or not the patients are treatment naive in aesthetics or not.
Yeah,
because if
that's
you've been
true.
handling somebody for 15 years,
Yeah.
they trust you, they know
Yes.
what's going on, they're losing the weight, they want what they had back. If they've never had these treatments and all of a sudden they're turning around, losing all this weight, they look thin. Everyone says, yeah, you look a little too thin. They're like, you know what, I'm okay. It's very hard to convince them otherwise. That's why those cases that you talked about are so important to build. There's one thing I would want to make a comment on, and that is the term Ozempic face. I think it's actually an unnecessary term. That's a company brand that is promoting one company's product. And I think that's fine if you have stock in it, and that's great. If you don't, maybe you should buy some. But the point of the matter is this should be a medication-driven weight loss discussion. And I think this is important because we're training the next generation of injectors. We're also training the next generation of people who are going to be treating these patients. And they have to maintain that level of objectivity when we're talking about this.
I have to say guilty as charged because I did use the term Ozempic face, but when I looked it up in the social platforms, that seems to be what is ringing in the lay ears. And so sometimes, when the patients are coming in, that's how they identify it, and they get a little confused by the details. But I agree with you with injectors and physicians. Perhaps we don't have to be so social driven.
Yeah. Physicians first.
Yes.
Well, and it's also something to be said is as we start to have more research, we will start referring more to the data that we have instead of sort of our observations.
There's one thing we haven't talked about that we should probably bring up is that a lot of times before we do anything, we use neuromodulators to relax. And so I'll show a picture earlier or later today where if you relax the muscles that pull down, then you allow the muscles that float up to work. And so I do start with that.
I think it's great. I think that's a wonderful strategy because they're used to it. They trust the neuromodulators or the neurotoxins. They know what can happen and you can control the result. I think it's a good leap of faith when they're starting.
And I agree, frankly, in all areas of medicine. I always try to remind people it's better to be proactive than reactive. And like you said, and these patients are so afraid and they want to lose the weight. And so when they're feeling heavy prior to the weight loss, they're wondering, why would you inject me? How is this going to help me? So having those images, which luckily we probably do with, not realizing these patients who are coming through our doors and showing them this is a patient that received this care prior and this is a patient that didn't. And you're going to look great once you kind of get on this journey, I think is important. Yeah.
I think you made a really good point that there's going to be the procedure or injection naive patients that are going to be very different than the ones that are used to it.
Mm-hmm. But they're seeking it out more.
Yeah,
for sure. I've seen that because now they've lost the weight. They're feeling very confident. They come in and they're like, oh, I want, just a little Botox or, neuromodulator. I want the, and of course, always using brand names, right? And you have to educate them like, this is not exactly the only thing that's going to, yeah.
Having said that, we also have a pitfall that we have to watch out for in treating these patients. And the pitfall is that we cannot predict the future. So there is an element and a proportion of these patients who will rebound and they will gain the weight back. Whether they stop the medication or they change their lifestyle is up in the air. So the bottom line is you have to be very careful. And we talked about fat grafting before. So there's two things. There's the issue of whether or not the fat actually that we harvest is actually working the same way it worked before they were in this kind of catabolic state. That's the first thing. The second thing is, when do you fat graft them? You got to make sure that these patients have been stable for quite a few months before you put the fat in, because if they rebound and you've put fat in their face, and they gain 15 pounds more than they were to begin with, that fat's going directly into their face. And that's very difficult to remove. So the bottom line is stability in the evolution of managing these patients. It's no longer you come in and this is the plan. You come in, this is the initial plan. I'm going to see you in a month, and close follow-up is very important. As they follow their weight, you follow your treatment recommendations. And once you're sure of the weight stability, then you can go into more permanent solutions. And that's one of the key things of planning forward with these patients.
Well, thank you all for joining us. It's been wonderful discussing this with you today. It's been a pleasure.